Good afternoon, students. Today's class is all about a distant friend of mine, Sheikh Amir. He gave me a call one day, seemingly worried. He was experiencing classic symptoms such as blurred vision, central scotoma, and metamorphopsia. So, I did a detailed slit lamp examination, a fundus evaluation, and took an OCT. This is how his OCT looked. So what do you think I'm dealing with? That's right. This is a macular hole, and today's class is all about macular hole surgery. So for this, let me share this with you. Until 1990, macular hole was considered inoperable. It is after which Kelly and Wendell introduced the 5-step vitrectomy technique that these holes actually began to close. So now I want all of you to focus on this video, because here remains the key culprit. Yes, it is this vitreous that exerts both the anteroposterior as well as the tangential traction, which results in the formation of a macular hole. That is exactly why the first step is vitrectomy, where you remove the entire vitreous. So now, do you just leave the tangential traction? No. How do you deal with it? That is when the ILM peeling comes into action. By the way, what is ILM? Very good. Okay. So, first we stain the ILM using a vital dye, preferably the brilliant blue G, and then using the ILM end gripping forceps, we peel the ILM. You heard me right? You peel the ILM. And what is the technique referred to as? The pinch and peel technique, where we pinch and we peel about 2 to 3 disc diameters of ILM around the hole. This relieves the tangential traction. So now, followed by a fluid gas exchange, because it is this gas that gives an internal tamponade which will help in approximating the edges of the hole. Post-operatively, we ask the patient to remain in the face down position, and caution, tell him my Dubai patient did not take a flight back home for several months. Okay, after that, now that we've walked through the steps of the surgery, let's see who as a surgeon you're going to operate on. Indications of surgery: those with a visual acuity of less than 6/12, lifestyle hampering metamorphopsia, stages 2, 3 and 4 of macular hole. Right beside you can see the gas classification. I'm not going to go deep into it because it was dealt in the previous class. Just remember that from stage 2 onwards, you are going to intervene surgically. Now, as time went, surgeons began to feel that this method did not work well for large holes, myopic holes, recurrent holes, as well as chronic holes. That is when they began to think, why remove it when you can just flip it? That gave rise to the most famous technique, inverted ILM technique. Here, the flipped ILM acts as a natural scaffold to close the hole. Okay. Now, think of the scenario when you're dealing with a really large hole, or you don't have any local ILM to flip or to peel. What do? That is what gave rise to this technique. Here, a superior wide flap is raised, and this will form a strong flap. Good to go? Okay. So now, when you don't have anything, use your brains. That is when we are going to innovate. We use anterior lens capsule, preferably for transplant, then also the neurosensory retina. And also keep in mind, dear students, some adjuvants such as fibrin glue and then autologous blood platelet concentrate and heparinized whole blood, which will also help in keeping the ILM in place. Going to the literature, it says that for conventional method works well for small to medium sized holes. And when you're coming to larger holes or myopic holes, the inverted ILM flap works good. And for very large holes, the Swift technique is superior. Now, what is anything without complications, right? So here also you can expect complications such as retinal detachment, enlargement of the hole, cataract progression, and very rarely end off. And my patient, he was extremely happy with his recovery journey that he actually sponsored my trip to visit the Burj Khalifa. And now I want you to know, in today's era, that closing the hole is not the real challenge. Regaining the vision, or in short, trying to find the right bridge for the right hole is. And there's a small homework for you. Find it out. I will do the teaching in the next class, but just put in some effort and just find the answer to it. And for the really enthusiastic to-be vitreoretinal surgeons out here, scan the QR code. You can see the whole procedure in action. Thank you.
Yes, madam. So they want to ask some doubts.
Sure, sure.
Yeah.
How long did you say your sheikh had to wait from
No,
taking
1
a
month.
flight?
That's why. That's after that he had gone actually.
What if someone needs to fly? Can they do some other surgery without a...
Actually, there is no positioning technique also. That is, there's a new trial, that is positioning in macular surgery. There's a PIMS trial, which says that we can actually do a surgery without the prone position also. It is shown that there are results. So that is also a way, but I didn't because he's Sheikh Amir, I didn't want to take the chance with him.
She wanted the sheikh to be here so that,
Yeah, I was expecting that sponsorship.
Ma'am, I was reading, hi. Ma'am, I was reading amniotic membrane also there in macular hole. Amniotic membrane in macular hole, I couldn't understand. What the use?
Look, when you see, that's a really brilliant question, young man. By the way, when you don't have something locally, okay, you just, instead of just trying to give up, that applies to life also, okay. Like, just sitting down, like, oh, I can't do anything. Try to resource it, no. Like, that is when it works, like lens capsule, or the neurosensory, or as you said, the amniotic. I'm impressed that you're doing the reading, actually. So yeah, that's it. Don't just say I can't do it. Like whatever it is, like if it's a fake or whatever, don't just say can't. No. Try to find an alternative, and this amniotic membrane that you said is such an alternative.
Teacher, I did the surgery,
Okay.
but my patient is not improving. The hole is closed. What happened?
Okay, so that is what I was saying. Macular hole surgery has come a really long way, dear one. You look really beautiful, by the way. And this anatomical closure has nothing to do with visual gain because the hole will close. If it's a small or medium-sized hole, it will close like in maybe if it's a small hole in 1 or 2 weeks, larger hole will take a time. But what depends in the chronicity, the duration of the hole. Maybe when the patient that you did, he had a hole maybe for like 6 months or more. And there are other factors. I will deal with that in the next class, but just giving you a hint that there are certain factors like the ellipsoid zone disruption, the photoreceptor integrity. So vision gain is a larger angle, it's a perspective. Holes will close. That is exactly what I told you last. If you paid attention, that closing hole, it's VR surgeon, marchers in it. But gaining the vision, it's luck. And yeah, you do your best thing and you pray.